Um, Welcome everybody. We'll start in a moment. Just a few things. If you can make sure you're on mute, and if you'd like to ask anything when we get to that point, if you could please use the raise your hand function, that would be great. And you're more than welcome to use the message function as well, and write your comments or questions in the chat function. That would be also wonderful. We're really delighted to have colleagues from Slough here with us today to share us. Do you want to go on to the slide with the running order for today? That would be great. So we got a bit of some insights from Slough on their work around homelessness, and then we're going to have a little bit of a discussion around winter planning and adverse weather planning, really, and some chance for discussion at the end. So I think we'll kick off because time is pretty tight today, and I'll hand over to Jamie and colleagues and Stuart in Slough, if that's okay.
Thanks, Emma. I'm just going to do a quick word of introduction, if I may. So I'm Mike Waldridge. I'm the Better Care Fund Programme Manager for Slough, but so working across integration, health and social care. And whilst our support for our homeless isn't kind of a BCF part of our programme, it is an example of our kind of integrated approach to supporting people in Slough. So I'm not going to say too much, but I'm going to introduce my colleagues this morning. So we've got Jamie's going to give a perspective from the Slough CVS and the work they've been doing through COVID, supporting our homeless people. And then we're going to hear from Stuart from the outreach team in the Borough Council, and then our GP clinical lead, Dr. Cam Samara, who's kind of been running some clinics to support our rough sleepers. Okay, so just next slide, if I may. Just very briefly for people who don't know, Slough. So Slough's one of 6 unitary authorities that form Berkshire, established over 20 years ago. The 6 unitaries. They're all a similar size, but Slough's quite a small geographic area with population around 150,000. It is, however, quite different for the others in terms of its very diverse population. So more than 54% are from BME backgrounds, over 11% are white non-English, and we've got about 8,000, about 62%, who don't speak English well or at all. 15.5% of households, no one speaks English as first language. High density population, large multi-generational households, and a lot with those with multiple occupation. And we have quite a large family homelessness population as well, which is significantly higher than our regional average. So I won't go regurgitate the whole GSNA because it's on our website. Hello?
Can you make sure you're on mute, please?
That's all right. So I won't go through the whole GSNA because it's on our website, but I just thought that's helpful just setting some background and context. And now I'll hand over to Jamie.
Okay, so I'm here to talk about our community response, which we named One Slough. My name's Jamie Green. I'm chairman of Slough CVS, but much more importantly than that, I'm a One Slough volunteer. Next slide, please. So our mission in One Slough is we will do whatever it takes to keep our most vulnerable residents as safe as possible during this dangerous time. We united our town under the One Slough brand, something that everyone could buy into. We have no logos, no egos. We work for our residents, we work for Slough, we work for our town. And an example of that would be, at the start of the pandemic, we had people from the voluntary sector working in the council building alongside the council workers, and people who work for the council working in Slough CVS's building alongside members of Slough CVS. Next slide, please. So with our community response, we felt it was very important to keep it simple. So we have one phone number, one email and one referral form. And that was the 3 ways that people could get in touch with us, and everything fed into a database of vulnerable people. So the referral form had questions like, do you need food? Do you need medication? Do you need a regular wellbeing call to make sure that you're all right, and things like that. We were responding to the most imminent needs at the start, and those needs were really access to hot meals and food parcels. They were very important. Access to vital medication and shopping, building resilience against social isolation, and we did that by making calls to people, and we ensured that we got multilingual volunteers in, because that's definitely a necessity in Slough, to make sure that we didn't miss anyone out and everyone could access the services. Next slide, please. So questions on referral forms and at call centres fed our database, which ensured our clients got the appropriate food for their nutritional needs. And again, in Slough, being a multicultural place, we needed to make sure we matched their cultural needs as well. To do that, we worked with the faith and community groups who are busy making food and food parcels for their communities. So we tied in with them, and any needs that we got through the database around specific needs like halal food and stuff like this, we ensured that we gave the information to those community groups so that they could do the work for us, and they could ensure that the right communities got the right foods and no one went without. Next slide, please. So a very quick snapshot of our dashboard, and I know we're pushed for time, so I'll just let you know that this was the dashboard that appeared, that was fed by our database. We could check on it at any time, and it was really helpful to us in planning our future strategies and looking at trends. So the dashboard and the database were, really the main things that we needed to focus on to ensure that we were getting the right things out to the right people at the right times. Next slide, please. We're very lucky in Slough. We have a strong voluntary sector. And right at the start of this, right in March, before even lockdown had started, we started our first weekly voluntary sector meeting online. We had 55 faith and community groups attend that first meeting, and we've been holding them weekly ever since. The average attendance is 25 groups, and it's really, really important to engage with those groups. We get to hear what they have to say, what they've been doing, and we also get to ask them we get to ask them about specific things we might need to know. So, for example, last week we sent out an email early to all the groups asking around what they felt that the barriers might be to people going out and getting tested. And then those 25 groups came back to us and gave us information from their communities, which was vital information so that we could look at our strategy on getting more people tested. The meetings are led by Slough Borough Council and Slough CVS. And this is really important that it's jointly led, because it achieves the buy-in of some of those groups that traditionally wouldn't necessarily engage with local authorities. Next slide, please. Obviously, lots of partnership working going on at this time. And the way we did things in Slough was we coordinated the response quickly and safely by using volunteers from existing community groups. Now, the thing when you use existing community groups, they've already got their own infrastructures and their ways of working. So all we had to do was tap into that. Their volunteers already had DBS checks. They had all the relevant safeguarding qualifications. And where anything was needed for a face-to-face service, we already had the right people to do it, which was amazing. Next slide, please. So in Slough, again, lots of furloughed staff and lots of unused spaces. And we were lucky enough to be able to use both of those. Our vital call centre that we set up at the start was set up by a member of an organisation in Slough that had set up call centres before, and they were on furlough. They also provided the training to the local authority and the volunteers to run the call centre. Community kitchens work with furloughed chefs from places like 5-star hotels in Heathrow, who are able to make amazing food of high nutritional value for our clients. The food was usually donated from the community and also some business donations, which was fantastic. So it meant it didn't actually cost anything. Langley College provided us 2 kitchens, which weren't being used during the pandemic, and they're still in use today. Chefs took those kitchens over and created meals for all the homeless people. This meant that not only were they receiving regular nutritionally balanced meals, it meant they didn't need to leave their accommodation to get food, which was really, really important. Next slide, please. Okay, so you may have heard me talk about food quite a lot. That's because it was our biggest issue in Slough, and I'm sure it was the biggest issue in a lot of places. We know that feeding people good food was vital to our community's resilience. The number one request we were getting was all of food-related issues. The most important thing we did with the homeless group was make sure that the food actually got to them. If you use a voucher scheme, it doesn't necessarily mean that those vouchers are going to be used for food. They could be used for other things that aren't as good for their nutrition. They could be traded, and it also means that you have to leave your accommodation to spend them, putting yourself in danger. After getting people to move into accommodation by explaining the situation and that you want to keep them safe, it's counterintuitive to then tell them to go out and get some food. Next slide, please. So the successes of these meals were fed back to us by homeless charities and SBC's outreach team. And there were some great quotes that we heard over the time. It's like the colour has returned to some of their faces. I've never seen them looking so well. And one of my favourites is that people are recognising it as a chance to really turn their lives around. Next slide, please. I'm just going to touch on the donations we mentioned earlier. So we had lots of donations from different organisations. Places like McDonald's weren't open at the time, so they had to get rid of the food that they had. So we had donations from places like McDonald's and other similar places. Slough Malecko is a supermarket in the town. It's a Polish supermarket. They donated £2,000 of food to the kitchen at Langley, and also £8,000 of cash. Now that £8,000 of cash that they donated came from their supermarket bag tax, and it was a quarter of their tax for the year. So imagine if we all could tap into a quarter of the bag tax of supermarkets in our towns. I think it'd be really, we'd be set up really well. So that might be something to look at for the future. Next slide, please. Okay, just a brief snapshot of where we were on 11 weeks. 5,621 prescriptions delivered, just under 15,000 hot meals delivered to vulnerable people, NHS, police and key workers. Just under 1,000 families were supported with food on a regular basis, and just under 2,000 families were supported by our food bank. 70 emergency food parcels were delivered, and another 10,000 non-perishable food parcels were delivered. Next slide, please. Just a quick note on our steering group. Steering group was made up by Slough Borough Council, the CCG, NHS Frimley Health, Thames Valley Police, Public Health Slough, and Slough CVS. Next slide, please. Next slide, please. Okay, just the next steps. I think we've skipped one ahead, but thank you. So what's worked really well was the steering group. The database was absolutely vital. The database enabled us to make sure everyone was safe. It also enabled us to go back later and talk to people and find out how they got in, so we could look at our strategy through what had happened and what was going to happen in the future. The weekly calls were absolutely vital. They gave us access to the voluntary sector. We could hear what was being done. We could assist and help with any barriers that they may have and look at trends and how things might be. And it helped to coordinate them. The Slough community came together very quickly over this, and the ability to respond was also very quick. Next slide, please. Next slide, please. Okay, my screen's not changing here.
No, mine isn't either.
Okay, as long as it's not just me. So the next slide should have been next steps. And for us and the local authority, it's about embedding One Slough into everything, about putting One Slough in the local authority's business plan, strengthening the infrastructure, really importantly, looking at that vulnerable database. And the vulnerable database is a database that's made up from all the information we have on people at the moment, and so that we can identify things that in the future might be relevant. So, for example, coming out of the pandemic, we have knowledge around things like people between the ages of 70 that live in flats may fall a lot, and that leads to other things. And then we can interrogate our database to find out who those people are that aren't already involved with adult social care, and put in prevention methods. And this is something we've never been able to do in this way before. So that's really, really important. Steering group will continue, and for the local authority, their plans are around stronger localities and a strong, healthy and attractive neighbourhoods, and they want to ensure that the voluntary and community sector is in that through One Slough. If we could go to the last slide, please. And then that's pretty much it from me. So thank you very much. I hope that's been helpful to some of you, and good luck with everything that you're doing.
Thanks, Jamie. Okay, I'm going to hand over to Stuart next, who's going to say a bit about the community outreach team and their role. Stuart, are you there?
I'm here. Yeah, good morning, everybody. My name's Stuart Adney. I work for Slough Borough Council. I'm an RSI coordinator funded by the Ministry of Housing. And in short, that means that I work with partnership agencies and a rough sleeping team here in Slough to try and help our street homeless population. First thing I'd say is it's just, obviously, I've only got one slide. I'm not quite as prepared as Jamie, but it's important to separate homelessness from rough sleeping. Rough sleeping is probably the most visual part of homelessness, but homelessness is a far wider issue, as I'm sure most of you are aware. Here in Slough, we have around about 374 households in some form of temporary accommodation currently at the moment. But obviously, I'm going to speak about rough sleeping and the pandemic. So our rough sleeping population, generally speaking, is around about 80% male. Most of our clients are 25 years plus. We don't have many young persons on the streets here in Slough. And there's a range of reasons why people may end up on the streets, from affordability issues, evictions from private rents, family breakdowns. As I'm sure you're aware, rough sleeping across the UK rose from 2010 around about 165% in around about 7 years. Here in Slough, we officially rose around about 110%, so we fared marginally better. And we started this around about 3 years ago in 2017 due to the ministry's funding. In that time, our official street count, which is a snapshot of one night of the year, has gone down, which is very positive. 2017 we had 29, 2018 we had 27 counted, and 2019 we had 25 counted. So that's very positive and shows the work we're doing. But that is a snapshot on the night, and we prefer here in Slough to try with our partnership agencies in homelessness to create a figure that we would see over a course of a year. So we, generally speaking, see 100 to 120 unique individuals who would probably spend at least one night sleeping rough on the streets of Slough. That can be literally one night for some clients, or others they can be entrenched rough sleepers who are out, every day of the year. So we are moving in the right direction, but there is still plenty of work to do. As Mike alluded to, we are a very diverse town here in Slough, and our rough sleeping population is very similar to that. We have around about at any given time somewhere between 40 to 60% of our rough sleepers who've got no recourse to public funds. They're either the rest of the world nationals who have failed asylum, or we have a high proportion of European citizens who are not exercising their treaty rights. So that creates us some issues with eligibility, language issues, and we have to sort of think about how we're working with that client group to support them and to ensure that they're getting every service they possibly can. The outreach team itself is myself as a coordinator. So my role is to, run our outreach service here in Slough. We have 3 outreach workers here who work with me, who go out to the streets, engage with people, try and build up trust in a group of people who the system has failed numerous times before for a number of reasons. Obviously, we will support people on the streets, make referrals into appropriate agencies, whether that's drugs and alcohol, mental health services, doctors, and also supported housing accommodation units and any other accommodation we have. And ultimately, our aim is to obviously get people off the streets in a sustainable way. The advantage, I suppose, that we have as an outreach team compared to homelessness teams is that we can just keep going. The way homelessness is set up is very much the client has to engage with the system, engage with the local authority, and we can go out, we can go and see people. When they're telling us to leave them alone, we will just continually return to them, try and build up that trust. And sometimes that takes a week, sometimes that takes 3 or 4 years. So it is an interesting cohort to work with. We work with pretty much everybody in Slough who has anything to do with rough sleeping and homelessness. So the voluntary sector, Turning Point, which is our drugs and alcohol services, the CCG, some of our housing providers, Look Ahead Housing, the YMCAs. Within the voluntary sector, it's very strong here in Slough. We have a day centre run to Slough Homeless Are Concern. They've been here 20 years. We have a good partnership with them. We also have another organisation called London and Slough Run, who assist us and run a winter night shelter with us. We've got a very good relationship with them. We have Salvation Army here who do drop-ins and serve food. And we've also recently started a partnership with Trinity Housing, providing some supported houses of multiple occupancy with coaches, which is going quite well so far. As part of that, we have a homelessness forum. It's kind of on hold with the pandemic, but that is run by the voluntary sector. But obviously we attend that with the police, with the Department for Work and Pensions, and that's an opportunity for all of the organisations to come together to discuss the situations that are happening on the streets and try and find some positive solutions in a joined up way. During COVID, we obviously had the Everybody In campaign that the government ran, as I'm sure you're aware. So the team were out and about at the end of March, start of April, working very immensely long hours, engaging with everybody on the streets, trying to ensure that everybody had somewhere to go to self-isolate, socially distance and protect themselves and protect the NHS. Here in Slough, we ran a range of accommodation for that. We had a commercial hotel that we leased with 40 rooms. We were also using some guest houses in Slough, and we had a number of self-contained units in case we had anybody with symptoms and we needed to actually self-isolate those people. So we made the assumption with our night counts and with our estimates that we would probably be looking to house around about 35 to 40 rough sleepers during the pandemic. We were up at 70 at one point in time, mainly because not all of those people were rough sleepers, but obviously with the pandemic, a lot of sofa surfers and single homeless people who in other times would find accommodation, albeit not permanent. People were worried. People didn't want people sleeping on their sofas. So we did see a massive increase in people approaching the service, ensuring that they had accommodation. Since March the 23rd, we have offered and housed in various forms of permanent and temporary accommodation around about 40 people now in accommodation. We've still got around about 20 to 25 people in temporary COVID accommodation, as we're calling it, and we're still working with those people trying to find a positive solution for them. I think that's probably just about me. I mean, the clients that we work with, as I'm sure everybody's aware, are very complex clients. There are a number of issues. We find trauma-based issues play a large part in what we're doing, so hence the reason we're working with mental health and the CCG. Addiction issues are a big issue for us, and trust, as I mentioned earlier. But I'll pass over to Cam, who'll talk to you about one of the services we run with an out-of-hours doctor specifically for rough sleepers. Thank you.
Thanks, Stuart.
Thanks, Stuart.
Cam, just before you introduce, I'm just going to say very briefly that our finding or setting up our clinical support. Obviously, we had this opportunity through COVID, but we've been trying to do that for a little time before that. So, just from a commissioning perspective, we had carried out a CCG, a quality impact assessment, looking at the needs of vulnerable groups, and we used some of our improved access to funding for Slough for some to commission a primary care service. So that's how we ended up through the out of hours service, having Cam kind of support through as a clinical lead. So that's all I'll say. Cam, I'll hand over to you now.
Thank you very much. Hello guys, my name is Dr. Sam. I'm one of the GPs that work locally and works for the out of hours service over in East Berkshire. Can we move to the next slide, please? Thank you. I thought I'd just give an outline of our journey that we've had together. Over in December in 2018, I was approached by the out of hours mental directors actually to think if there's any way that we could provide a service with the council and the CCG to help with our homeless patients that are resident in Slough at the moment. We decided to use a building at Turning Point initially. In January 2019, we set the clinic up slowly. The uptake wasn't that great, and we had to have a look. We had to have a little think about how we could improve the circumstances and what barriers that we had. The next thing that we did is in April 2019, we had a homeless walk. That's with Stuart and the outreach team with the council, and that actually proved to be quite productive as it gave an opportunistic time to actually approach these patients in their environment and to try to gain some trust, which is very important, which is what I found over the last 2 years. Since then, we developed a homeless walking clinic that is operates out of hours in the local walking clinic from the hours of 8 to 10 on Tuesdays. And we had a successful flu jab drive last year, and we should be doing that again this year. As Stuart touched upon earlier, patients were housed at the Datchet Manor Hotel, and that was another opportunistic approach that we had to actually see and review these patients, as literally they were in lockdown, they couldn't go anywhere else, and that was a good opportunity for us to gain some trust as well. Currently, we've just started working out of a shelter that's been built by Look Ahead, and that's in Slough. We've actually had our second clinic yesterday, which has been successful as well. Can we move to the next slide, please? So that just gave an overview of our journey together as to what services and where we have provided them. It has been a journey over the last 2 years. We've noted we've had to come across some barriers and think of out-of-the-box ways which we can overcome these barriers. One of the biggest barriers that we had was location. So when we first initially started, we were at Turning Point. The building, unfortunately, was a bit far away from the town centre and a bit far away from where the rough sleepers or the homeless patients were. So we had to come up with an idea together after doing the homeless walk to try and find an area which is more central, which is more central. Language is also a barrier to actually providing care for these patients, especially as we speak. Stuart mentioned we have people from all across the world, but also Eastern Europe, Asia. Luckily, we have a good outreach team with people that are able to speak different languages and provide formal translation. But also with the assistance of East Berkshire out of hours, I'm able to access their language lines, which give formal translators 24 hours per day. The homeless walk was fantastic because that actually showed to me how much fear there is of actually seeing any healthcare professional. When I say fear, is a lot of these patients who are unfortunately homeless seem to think that as a doctor I will speak to the police about their drug use, or I would contact the Home Office if they are from abroad and don't really have recourse to public funding. By actually going out to see them, liaising with them, and actually building up a trust, we have managed to develop a patient base and get patients in to be seen now. We've also developed the clinics that we have, and we're integrating the help of nurses now, and hopefully mental health team in the future. Can we move on to the next slide, please? I thought that I would give you a couple of cases just to give an outline of how the different strategies we have used has been helpful to patients. The first one is that of the Datchet Manor, the Manor Hotel in Datchet. It was a 32-year-old female who had been booked in to see us 3 or 4 times in the last month, but never actually attended any of the appointments. Now we actually were able to see her because she was housed in the emergency Datchet Manor Hotel during COVID, and actually she agreed to come down and see us there. On further questioning, she actually had a neck abscess that had been festering on and off for some time. And after engagement, gaining trust, and speaking to the patient, we managed to actually get her the treatment she needed, which was actually an emergency admission requiring a small procedure. And since then, she's actually started to engage with us in the community in our new Look Ahead clinics. And she's actually on a maintenance script as well with the drug and alcohol abuse services locally. Next slide. The second case I wanted to discuss was a 33-year-old chap who we actually saw, well, I remember quite vividly seeing him with Stuart on the homeless walk. He was actually residing in the bin area of a block of flats. He was quite apprehensive about seeing anyone at first, especially a doctor. It took a good 5 to 10 minutes just to explain who I was and what my role was, and also basically explaining that I'm not part of the police or trying to move him out of where he was staying. He was quite unwell, actually. This is where the importance of teamwork was highlighted, as even after a long 30-minute conversation with him, he declined to take any of the actions which I thought he needed. The big one was that he had a large abscess in his leg that needed drainage, and that could actually become limb-threatening. Due to the cohesion of the team that we have, Stuart actually and the outreach team went to see him a couple of times the next day. due to the fact that he had that contact, he actually ended up agreeing to go. He needed 2 procedures in the end and was actually treated for TB as well locally at the local hospital. I've actually met him for the first time after 4 months yesterday. He's actually housed at the moment. He's engaging with services such as Turning Point, and he's actually making improvement in terms of his mental health as well. But these 2 cases just highlight how number one, it's been difficult to start off with, but how much of a difference actually having a wide range of support in terms of medical and as well as the outreach team with the council has helped to at least provide these patients with some good healthcare. Next slide, please.
I think that's me. I was just going to say, yeah, in terms of next steps overall, Cam, thank you. That yeah, you mentioned already that we've established the Look Ahead clinic there. So having followed the opportunity of the Manor Hotel, we wanted to establish that on a more permanent footing, and that's where we're looking to host it, which is great. The opportunities now can extend and develop the service. So we've been talking about the Hep C testing and getting that in to do that where required. We're coordinating with the Drug and Alcohol Service already, but kind of establishing that on a more permanent footing as an integrated service with mental health, hopefully. And we've had some interest from clinical pharmacists locally to support us here. So that's going to be, I think it will just develop as we go forward. As Stuart's mentioned, we've got new accommodation coming online. So we've been fortunate to house people who were temporarily taken in. So again, using that as an opportunity to keep people in a more permanent basis and prevent them. I have been talking about kind of preparation for winter, which is kind of the next part of this session today. We don't know quite what the future is going to hold in terms of night shelters as they were previously, but we'll keep that under review. They may not be permitted because they are kind of shared spaces. So we'll see what our numbers are and what the guidance is, and whether we indeed need have a need for those for this coming winter. So that's all from us, really. I'm happy to take any questions from people who might have.
Thanks ever so much, Jamie. That was fantastic. We've had a few questions in the sidebar. I think what we'll do is we'll take a few questions now because we've got a few minutes, just because I think it'll be useful to do this part now. And there are a couple of questions that relate to the next section, which we'll take now because they'll lead us nicely into the next bit anyway. A couple of the questions have been answered in the chat, but I will just pick them up so that everybody's aware of what's been asked. And if there are any further comments that you guys would like to say in relation to those, then please do. So there was a question from Andy about whether One Slough link into the government shielded household database, and Jamie, you mentioned that you have access to the database and that One Slough supported those needs, and Ramesh, you've kind of talked about some of the support. Is there anything else you'd like to add to what's already in the chat on that?
No, I just think it was, One Slough is a partnership, and works a partnership with the local authority around the shielded database to support those needs.
Brilliant, thank you.
I'd just like to add one thing, really, to get the message out, which was that so the shielded database had a lot of control over it, so we weren't able to share it, but we were able to get referrals. What we did was create a separate database of vulnerable people that we were all working together on One Slough with, which reached about 1,000 people. And that was accessible by both local authority staff, the voluntary sector staff, and some of our key providers. And that made a big difference because we were able to update records on the go from different locations and keep a track of people. And in one scenario, there were about 5 people that we had no idea what was going on with them because they weren't answering our phone calls. But we managed to get volunteers out onto their doorsteps to find out what had happened. And in one case, they were just hard of hearing and couldn't get there. One case, somebody had gone into hospital, and we were able to follow that up and give them support. But without one database that everybody could share, it was very difficult not to do a comprehensive service the way that we did it.
Brilliant, thank you. And Andy asked of those patients, homeless individuals who were housed in local hotels, have they now had to leave? And if so, where are they now? I know you mentioned that some have left and you've got about 20 remaining.
Yeah, yeah. Sorry, hi, it's Stuart again. So yeah, we had 40 rooms booked with the Manor Hotel in Datchet, and in essence, we took that on a 3-month contract. So we had people in there for 3 months, and by the end of that 3 months, we were down to around about 21 people. Most people were offered accommodation. Some people did leave the accommodation. Some people refused to come into accommodation. So of those 21, we made offers to people. So most have been replaced. We reconnected some with family and friends. But as I said to you, we have an issue here, issue is the wrong word. We have a challenge here with no recourse to public funds clients. So it's really difficult for us. People can't access benefits, do a lot of cash in hand work. But we have started a new scheme with London and Slough Run, one of our voluntary sector partners. So we have at the moment 2 properties temporarily on a 3-month basis for 6 guests who've got no recourse to public funds. And the idea of that property, for example, is that the European citizens will enter that for 3 months. We provide a support worker, and the idea is that we will get them eligible by helping them to seek work. Obviously, we've been providing them with passports, PPE for construction sites, trying to find them authorised work, and then we're helping them to move on. So the vast majority of people who came in for COVID have been made an offer. There are a couple who have left without an offer, sadly, who didn't want what we were able to offer them. But yeah, the vast majority are still inside in one way, shape or form, which is great news.
Fantastic, thank you. And we've got a question. I'm going to leave the questions about flu because we'll pick those up at the end when we go into the next segment. But a question about funding and how the initiative have been funded so far, both health and social care elements, and what's the expectations for future and kind of sustainable resourcing.
So just in terms of the primary care element, I said that's been funded through our extended access, which is due to end the end of this financial year, but we are hoping to make the case to continue that on the basis of the benefits and outcomes we've achieved through this. In terms of the outreach support, look for you, Stuart. Have some funding, some grant funding for that.
Yeah, so we're funded on a yearly basis under the Russell Lippin initiative from the Ministry of Housing. We're obviously hopeful that's going to continue. There's no indication that will stop, and I have to take my hat off to the Ministry of Housing. Obviously, we're just bidding for some more money now as part of trying to keep everybody in. So there is the Next Steps accommodation programme, which has just been released. So we're just looking through the prospectus for that, and that's in relation to ensuring that we have the right types of accommodation. And again, we're confident that we're going to get some more funds from central government to continue the work we started and hopefully keep up with the results.
Brilliant, thank you. I think we'll leave that there for now. If you've got any further questions you'd like to ask, then please do either put them in the side chat or email them to us, and we'll seek some answers for you. And we'll make sure that comes with the recording and things when we've finished and tidied it all up. We'll go on to the next element, and I'll pick up the flu questions as part of the next section. If colleagues from Slough are still able to remain on the call, that would be fab, because there are a couple of questions relating to the Slough model around the flu campaigns that you've run. That would be really helpful. There are a number of slides in this section, and I don't propose to go through them in masses of detail, but you'll have them. So some of the detail that are in them you can obviously refer back to at a later stage. So we'll just flick through them quite quickly and have a bit of a discussion at the end. So obviously the heatwave plan recommends a series of steps, and there you can sign up for alerts for these, and which the alerting system for the heatwave plan runs from June to September, and this just gives you an indication of different levels in terms of whether you need to be kind of on alert and to watch out for others and watch out for possible things you need to consider. We've got the resource and the link to that at the end of the checks. Next slide. Obviously, there are a number of impacts of hot weather, and particularly for this client group and many of the people we work with is the exacerbation of respiratory and cardiovascular diseases or illnesses. And if you go on to the next slide, it's just a picture that kind of shoots that. There are 2,000 heat-related deaths a year for this. So it's, you know, a real issue for us to think about as we start planning for going forward. And this just kind of illustrates some of the things we need to consider in relation to heat-related illnesses. Next slide. I guess for us, in the context of COVID, the key issue is that COVID kind of amplifies those risks, not only because of the fear of COVID, and you know, prevents people from taking action. We've got to support individuals as they kind of start to think about easing of restrictions, but also there'll be people that are fearful of coming out of their homes still as a result of that. And as the weather improves and gets warmer, there are cohorts of people that we need to kind of be aware of that may find that difficult. Next slide. So there are certain groups of the population that will be affected by high temperatures and COVID, and they're the same groups that have been affected by COVID itself. So there's an increase in exposure to indoor overheating as a result of COVID restrictions, and whilst these have eased, there are still a number of people that have been advised to stay at home as much as possible, and that has reduced access to cool places, particularly if you think of care homes and some other settings and some of the settings that individuals might be in. Next slide. Obviously, everybody can be affected by high temperatures, but there are other individuals are more vulnerable, and for us in particular, the environmental factors and overexposure, so the homeless population are a crucial one when we think about some of these key high risk groups. Next slide. Again, this just emphasises that many of the settings have restrictions in place, but as we know, these are being eased, and as people find themselves back on the streets and in shelters, then the risk of exposure to heat and to COVID is potentially increased. Next slide. So the link to the guidance is there. There are figures 3.1 and 3.4 in there, useful to follow, and need to think about kind of how we mitigate some of the risks around this in relation to, and think about that in relation to COVID. Next slide. Resources are all there for you. Don't need to say any more on that. Next slide. Winter is coming, and obviously, whilst it's not all doom and gloom, we've got the potential of a second wave coming at any time. Kind of various modelling I've seen looks at various points between kind of October, November, December time for a possible second wave. So right during the flu season, and obviously the height of winter. Next slide. Obviously just mentioned that, so I won't dwell on that again. Next slide. Obviously we've got major challenges for the homeless community in relation to winter. You're already doing massive work trying to look for accommodation in a climate of a lack of accommodation. the loss of night shelters and other communal settings. So the line from MHCLG and PHC on this is that night shelters can't open at the moment. PHC are working with some charities about what that might look like if a shelter was to open, but it certainly wouldn't look like shelters look now. So night shelters in their current form or what they looked like before are still not allowed to open. So there's a lot of work that we'll need to do in terms of planning for winter to support individuals in the height of winter. As we know, the pandemic and Slough obviously touched on that, and Brighton also touched on the kind of numbers that they ended up kind of supporting in the emergency accommodation. It wasn't just the people that they knew about on the streets, you know, the kind of hidden homeless, the sofa surfers, the others, those with in much more unstable accommodation is probably going to come to the fore as we move through the pandemic, and people in kind of on the verge of homelessness as the pandemic has taken its toll in terms of family breakdown, unemployment, and all of the social kind of determinants that have that will begin to play out as we go through this is likely to increase the strain on the communities and local systems to support. Next slide. Obviously, we need to prepare now. I know it seems far away, but as you're starting to develop your bids and your proposals for tranches of money around next steps and various other things, it's really important that we factor in winter and what you might need to support these groups going through the winter programme. Next slide. In terms of the flu vaccination, flu programme has been announced, but we're expecting further detail shortly. The current eligible groups are as they were, but there's been kind of an announcement that this is likely to be extended. What we don't know yet is whether that will include, be explicit around the homeless population. It's likely to be that there's something around health equity in there, which will probably allow us to encompass the homeless population and inclusion health groups within that and be able to extend the eligibility to these types of populations, but we don't know that for certain at the moment. The other group that we're really keen to be able to vaccinate are staff. And at the moment, the eligible groups include health and social care staff, but staff working with this client group aren't always included in those. So we're really keen to see if we can push any extended eligibility criteria to include those types of staff moving forward. And obviously, we've got the possibility of a coronavirus vaccine coming at some point. Some say December, could be early, more likely at some point early next year. But we need to be ready for those new deliverable models to be deployed. Next slide. Just resources where you can access kind of the cold weather plan and alerts for that sort of thing there. Next slide. More resources. Next slide. And that's it. So questions. There are a couple of questions from the last bit that I'm keen to pick up before we go into other questions. So Aboya asked about your flu drive, Cam, and would this be a good model for COVID vaccination if and when that comes online?
Thank you for the question. Not just bureaucracy, but you have to make sure that, for example, flu jabs will need to be done properly. For example, we have the backing of our out-of-hours service, East Berkshire. They have a sister surgery where we're actually formally, temporarily registering patients there. So you need to check, number one, in a nutshell, yes, it could be used for the COVID virus, but there's a lot of checks that are actually involved. For example, we have to do a SOPs for the homeless clinic. Also have to make sure it's safe in terms of the area where we're going to do the immunizations. We're also having to check whether or not they've had the flu jabs done at their own surgeries as well. So in the future, when the COVID vaccination is available, we would be using the flu jab model that we have used successfully last year again. However, how we would do that, it does take a lot of work. It means integrating with the usual GP services. It means a lot of work behind the scenes from our admin team in East Berkshire as well.
Brilliant, thanks, Cam. And there was another question about flu jabs and kind of the legal, safety and technical challenges and how you overcame those.
So, because obviously I work in my day-to-day job around today, I work in the GP surgery. So we actually thought about, so before we even went on to actually offer the flu jabs, we did with the medical directors in out of hours, but also the chief exec, I had to look at the actual guidelines. So all the immunizations that we're doing them formally. We're actually giving the patient sometimes even a sticker so that those patients that don't remember whether or not they've had it, they have a little card that says they have had the flu vaccination. It's even from a safety perspective, because if you are going to run a clinic where you are giving flu jabs, you need to think of where are the needs. You need to have adequate resources for example, sharps disposal, but also after this procedure, how are you going to dispose of the sharps pin itself? Thirdly, is there an emergency kit available in case of anaphylaxis or reaction, as we call it? Which so all these things needs to be taken into account, which we did. I mean, set up the flu to go around setting up a flu vaccination clinic. We actually went to Salvation Army per se and had an area there, but the actual work behind it took almost 2 to 3 weeks to make sure that legally it was safe, and two, it was safe for both us as clinicians, but also safe for the patients as well.
Brilliant, thanks, Cam. Anna from Homeless Link has kindly put a link in the chat to the homelessness and hot weather information that they've got on the Homeless Link site. Really useful to have a look at that, and we'll make sure that's shared in the notes. Any other questions on that for now? We're expecting further stuff to be published in the next week or two. So as soon as we've got any further things around eligibility and so on, we will let you know. No? Lovely. Last slide. So just to give you a bit of a flavour of what's coming up in the next few meetings. So next week, what we thought was, my very bad chairing skills. I was meant to ask Lucy to talk a little bit, Lucy Baker from MHCLG, to talk a little bit about what we were going to do next week before she had to leave the call, but she's already left. So that was a bit of a disaster from the start. But Lucy is going to do a little bit of an update around the next steps, planning stuff from MHCLG and the prospectus next week, and we'll do a bit of a discussion around that and about where people are at and any issues and things. And we'll also be sharing the pretty much final draft of the transition framework on Monday in preparation for that discussion, so that we can start to think about how the two kind of work together, and you can hopefully start using the framework as you start to kind of develop your bids for various things going forward. So we thought we'd use the time next week to have a bit of a discussion around the prospectus and where you're at with that, and if there are any issues that we kind of need to unpick around that. On the 6th of August, Bournemouth are going to talk a little bit about their pop-up Hep C screening work that they've been doing and work on bloodborne viruses, building on the discussion we had last week on Portsmouth's kind of really quick work project that they set up last week. And then we've got a few ideas that we're going to kind of test out with you going forward. So what we're going to do is put a little bit of a select survey together and send around about areas that it might be worth having some topic discussion on that link to the transition framework, and get your thoughts really on whether those would be useful for future kind of conversations, webinars, debates. So I think we'll leave it there for today. Thanks ever so much for joining us. If there are any other questions that you'd like to ask, then please do come back to us and we will get answers for you. The webinar has been recorded, and we will put question and answers together and get that out to you as soon as we can. Thanks ever so much, everybody.